Today, we're going to talk about a surgical procedure that, on the surface, sounds completely backwards. We're going to treat a disease that's caused by a loss of lung tissue by removing even more lung tissue. I know, it sounds crazy, but this is the incredible story of lung volume reduction surgery, a radical idea that completely reshaped how we treat one of the most debilitating lung diseases out there.
You know, for millions of people who live with severe emphysema, this isn't some hypothetical question, it's their daily reality. The simple act of breathing becomes an exhausting fight, as old, stale air gets trapped inside their lungs, making it feel impossible to ever get a full, satisfying breath.
So here's our game plan. To really get a handle on this amazing surgery, we're first going to explore the disease that turns breathing into a battle. Then we'll look back at the risky, almost forgotten history of the first surgical attempts. After that, we'll dive into the landmark clinical trial that changed everything. We'll see how the modern procedure actually works, and finally, we'll deliver the verdict on its real impact.
Okay, first things first. Let's get right to the heart of the problem, because to understand the solution, you've got to understand the disease itself, which all starts deep down inside the lungs.
So what is emphysema? Well, it's basically a process of destruction. It goes after the tiny, super delicate air sacs, the alveoli, which is where all the magic happens, where oxygen gets into your blood. Think of a healthy lung like a brand new sponge. It's springy, it's elastic. But in emphysema, that sponge gets all stretched out, floppy, and waterlogged. It loses that natural ability to spring back, what doctors call elastic recoil.
And this kicks off a really devastating vicious cycle. Without that springy elastic support, the little tiny airways start to collapse every time you try to breathe out. So old, stale air gets trapped. This causes the lungs to overinflate, a condition called hyperinflation. You can just imagine what this does to the diaphragm, your main breathing muscle. It gets flattened out by these huge, overinflated lungs, making it super weak and inefficient. Every single breath becomes a monumental effort, leading to that profound shortness of breath we call dyspnea.
For decades, there weren't really any good treatments. So surgeons, kind of at a dead end, started to consider a really radical idea. What if the most diseased, useless parts of the lung were actually the problem? Could removing them somehow help?
Now, this wasn't a totally new concept. You have to go all the way back to the 1950s, when a surgeon named Dr. Otto Brantigan first tried this out. The logic was pretty sound. If you remove the most useless, overinflated bits of the lung, the healthier parts would have more room to work, and the diaphragm could get back to its normal, curved shape. But the results were, well, they were not good. The procedure was pretty much abandoned for almost 40 years, until Dr. Joel Cooper decided to give it another shot, this time with modern surgical staplers and much better patient care.
So why was it abandoned? Well, get this. In Dr. Brentigan's original group of patients, the mortality rate after the operation was a staggering 19%. That is almost 1 in 5 patients who didn't survive. The risks were just way too high.
In this quote right here, it just perfectly captures the paradox that totally baffled the medical world. How in the world could you treat a disease that's all about the loss of lung tissue by removing even more of it? It seemed to fly in the face of all logic, and that's why the whole idea was just pushed to the absolute fringes of medicine. But then, Dr. Cooper's promising new results in the 90s lit a fire under this whole debate again. Was this surgery actually working, or was it just another false hope? The controversy got so intense that the National Institutes of Health finally stepped in to fund a massive, definitive study, the National Emphysema Treatment Trial, or as everyone calls it, the NET.
The trial was basically set up as the ultimate showdown. It pitted lung volume reduction surgery, LVRS for short, head-to-head against the absolute best medical therapy available at the time, which included things like medication and a really intensive pulmonary rehab program. The goal was simple, to figure out once and for all which approach was actually better for these very sick patients.
But before the trial was even over, the researchers made a truly shocking discovery. They took an early peek at the data and found a very specific group of patients for whom the surgery wasn't just not helping, it was actively harmful. These were patients who had a combination of really bad things going on, incredibly poor lung function, plus either emphysema that was spread evenly throughout the whole lung, or a severely limited ability to get oxygen into their bloodstream.
Now, for this specific high-risk group, the mortality rate just 30 days after surgery was 16%. This was a devastating number, almost as high as the rates that got the whole procedure shelved 40 years before. But here's the kicker, the absolute game changer.
For the high-risk patients who got medical therapy instead of surgery, the mortality rate was zero. Nothing. Not a single person. That black and white contrast was the undeniable proof everyone needed. For this particular group, LVRS was a dangerously bad choice.
So you see, the NET trial did something even more important than just saying, yes, this surgery works. It defined the rules of the game. It gave doctors a scientific, evidence-based roadmap for picking the right patients, and in doing so, it transformed a really controversial operation into a precise, life-saving tool. It wasn't about if it worked, it was about who it worked for. Okay, so armed with all this critical knowledge from the NET trial, how is the surgery actually done today? Well, as you can probably guess, those lessons now form the absolute foundation of every single LVRS program in the world. This table pretty much lays out the modern rulebook. Look over on the right, under exclusion criteria, you'll see that high-risk profile from the NET trial. Those patients are now an absolute no-go. The ideal candidate, on the other hand, is over on the left. They typically have disease that's mostly concentrated in the upper parts or lobes of the lungs. And this is so key because it lets surgeons take out the most useless tissue, which in turn allows the healthier lower parts of the lung, which do most of the work for breathing, to expand and function properly. It's all about precision.
So what actually happens in the operating room? Well, usually the surgeon will make an incision right down the breastbone. That's called a median sternotomy to get a good view of both lungs. Then they physically find the most diseased, overinflated areas. Using a special surgical stapler, they carefully remove about 20 to 30% of the lung's total volume from those target zones. And then there's a really critical final step. They reinforce that staple line, often with processed tissue from a cow's heart sac, to basically act as a buttress and prevent air leaks, which can be a really major complication.
All right, so after this long, incredible journey, from a risky experiment to a scientifically proven procedure, what's the final verdict on lung volume reduction surgery?
Well, for the right patient, the results can be absolutely life-changing. Just look at this chart. It shows the average improvement in what's called FEV1. That's basically a measure of how much air you can forcefully blow out in 1 second. For a typical candidate, their lung function can nearly double, moving them from being severely impaired to a much more functional level of breathing. The legacy of this surgery is just profound. It's not just about improving breathing numbers on a chart. It improves actual lives. It allows patients to do simple things again they thought they'd lost forever. It's also this shining example of why rigorous, evidence-based science is so important in surgery. And it proves, beyond a shadow of a doubt, that sometimes less really is more.
The whole story of LVRS leaves us with a critical question, and it's one that extends far beyond this one operation. In our modern age of incredibly powerful and specific therapies, the biggest challenge isn't just about inventing new treatments. It's about perfecting the science of knowing exactly who will benefit, to make sure that every single patient gets the absolute best shot at a better life.